Welcome to our program today. I'm Carson Porter from Accountable Care Law and Policy, and we're here at the campus of Greater Baltimore Medical Center with the CEO, Dr. John Chessare. Formerly of Italy with a different name and a different spelling, but Americanized to Chessare. Very interesting fellow who has founded and led the charge here at Greater Baltimore Medical Center to create an ACO, and that's why we wanted to sit down and talk. Doctor, one of the things that impressed me so much when I've looked at your blog, which, by the way, folks, if you haven't seen his blog, it's very impressive, is the whole concept of the quadruple aim. The government talks about the triple aim: better health for bigger populations, better care, and lower cost. You've added a fourth element, and I'd like for you to share that with our audience, please.
Sure, thanks, Carson. Well, you know, I've been in healthcare a long time, and I think all doctors, nurses, other clinicians, and even parking lot attendants in healthcare are fundamentally go to work trying to help people.
Absolutely.
And I think in the hustle and bustle and in the stress in the current system, sometimes we squeeze the joy out of the provision of care. So we wanted to try to put that back in and formally call it out as the fourth aim. So we call it the quadruple aim of better health, better care, lower cost, and more joy for those providing the care.
Well, once you've identified the concept of more joy for the providers, and I agree with you 100% on your main premise, I do believe that people who gravitate towards healthcare positions generally want to take care of people.
Absolutely.
But too many times the regulations and the bureaucracy and everything gets in the way. So how do you practice here in order to be able to cut through all of that so that they can be joyful?
Well, Carson, it starts with focusing on who it is that we're serving.
Right.
I think everybody understands that we're at a significant crossroads in our country. We spend 40% more than any other organized country in the world on health care, and yet our outcomes are not any better, and in some cases they are worse than in countries like Germany, Sweden, the Netherlands, France, Japan. And we spend a lot of money on things that don't actually add to better health or better care experience. So we try to keep people focused on a very simple phrase: what if it was your daughter? We created a vision statement of where we want to take our company, and then we reduced it to the vision phrase: to every patient, every time, we will provide the care that we would want for our own loved ones. And we call it out religiously and frequently. And then we tell people that if it were your loved one, you would want the best possible health outcome with the best care experience with the lowest cost.
Mm-hmm.
In this moment in our history, that lowest cost one is critical. Since the economic downturn, employers have pushed most of the added expense of health insurance onto their employees. So now we find ourselves in a position that even if you have health insurance, you may have such a high deductible or copay, you still can't afford the care. Rallying people around the "what if it was your daughter" phrase really gives them the visceral need to get in the boat with us and make things better.
Well, it's a wonderful touchstone for people to be able to visualize what we're trying to accomplish. You remind me of somebody I knew years ago who had a chain of nursing homes, and they created a similar concept called total customer satisfaction. And they had buttons that said TCS that everybody in the nursing home wore, and occasionally there would be a debate: are we doing the right thing or not? And it would come down to, does this enhance total customer satisfaction or not?
Yeah.
A little bit different way of expressing the same sort of concept.
Absolutely. And just as a little sidebar, I was a practicing pediatrician until a few years ago. And we doctors and my colleague nurses too, we hated buzzwords.
Yeah,
and
sure.
We hated phraseology. And it was so easy to, so somebody says total customer service and their intentions are absolutely pure, but we have a tendency to spin that off into, yeah, this will go away. So at GBMC, we've tried to avoid buzz terms and buttons.
And how do you ingratiate, how do you embed it into the culture of the organization?
That's
the real key.
That's the question. I don't have a simple answer for that. We have embraced the science of improvement, and we are pushing the issue of organizing in teams, designing systems focused on who it is that we are serving, and then measuring the performance of those designs at regular intervals. And people will not do this on their own. I joke with my senior team that I've been around a long time, and I used to think if I could only tell the story really well, everybody would go off and improve things. And that is necessary. It's necessary to get in their hearts, but it's insufficient. So we've now embraced performance improvement tools, and we set aside a percentage of our budget to set people off in teams to redesign the system. So the critical redesign that we are doing, and we're redesigning everything, but the critical redesign is to redesign primary care at a granular level using the so-called patient-centered medical home as the fundamental building block of an accountability for better health, better care, lower cost, and more joy.
Explain to our audience how you are implementing the patient-centered medical home.
So we have built a primary care network. In 2010, I think we had roughly 30 employed primary care providers, both physicians and mid-levels, and today we're up to about 100. We created
now these are full-time employees?
Not all. We've created a new company that we're calling Greater Baltimore Health Alliance because we also think that it is the strategic advantage of many community hospitals to be aligned with private practicing primary care doctors. So of the 100, about 18 are private practicing, and we want to grow that number bigger.
Do you find greater challenge or less challenge trying to implement with employees versus private practitioners?
We find somewhat greater challenge with private practicing physicians because they also have the added burden of their own company bottom line and their own way of doing things. And what we've said to people is we don't need to run their office as long as they are willing to commit to a compact. And the compact is fairly simple. Point number one, they must sign on the dotted line that they are committed to the quadruple aim. Number two, they must commit to the principle of collaboration, that they will come with an open mind.
A new concept for some of these practitioners.
A new concept for some people, and that they will share data and they will delight in improvement. We can't ask them to do everything that our employed group might be able to do because, quite frankly, generally the employed group, we have put more resource for improvement in the employed group, but they must commit to the compact. So within that 100 providers, we've got them in offices, and we've got leadership dyads in each office, so a physician leader and a practice manager. And we are working with outside colleagues and internal redesign experts to get everybody up to the standard of level 3 certification on patient-centered medical home. Some people believe that the new world is just about getting a lot of primary care doctors and putting them in a company and getting, market clout by having a lot of primary care docs. We believe it's way more than that. You need to redesign the delivery system at a granular level, and you need to get the primary care physician as the captain of the team to say, yes, we will be held accountable for better health, better care, lower cost, and more joy for our employees. And then you have to turn them loose on redesigning their systems to be able to do that.
Do you have full integration of information technology with these people?
We have gone from zero integration of information to fairly well integrated information, but we're not at the finish line yet. We have everybody using the same outpatient electronic record, and we now have information sharing across databases. So we can cull reports that include all of the primary care offices. We can send information electronically from one to the other. We send information from our hospital to the primary care record, and from the primary care record to the hospital. We receive information from other hospitals through the state health information network, which in Maryland is called CRISP. So we get downloads on a daily basis of who has been in other facilities. But we're not totally there yet. So, many of our specialists are not yet connected, and we're working on that.
Well, piggybacking on what you're just talking about, there's two topics I want to make certain we touch on before we wrap up here today. First one is ACOs, and the second one is the portal for patients that you've created, which I find fascinating. Let's talk a little bit about ACO certification and the development of the Greater Baltimore Health Alliance, I think it's called, right?
That's correct. Well, so if the patient-centered medical home is the fundamental building block,
right,
the entity that will oversee the functioning of the patient-centered medical homes is the Accountable Care Organization.
And you're one of 4 that's been certified in Maryland, I believe.
I think it's up to 6 right now in Maryland, I believe. We are one of 2 that has a hospital in it. Mm-hmm. As you know, Carson, the whole movement is to go from hospital-centric to patient-centric, and you need the patient-centered medical home as the foundational building block for that. The Accountable Care Organization is the structure within which the money flows, the information flows, the overall reflection occurs. So the board of the ACO is almost all physicians and mid-level practitioners, and they meet at regular intervals to assess how are we doing at managing the health of this population. How are we doing at the triple aim? Are we lowering costs by driving out waste? Are we improving health? Are we improving the care experience?
What kind of tools are you using to measure that?
Well, we are submitting required data on things like patient satisfaction, patient engagement scores. We're submitting data on process measures of care, like core measures and other clinical process measures. We submit data on a handful of outcomes of care now. We actually get data fed back to us from the federal government because we are in the Medicare Shared Savings Program.
Right, sure.
So CMS shares data with us.
Did you take one-sided or two-sided risk?
We took one-sided risk.
So that goes for what, about 3 years?
The program is the first deal is for 3 years, and at the end of that 3 years, we'll see where we are, and I'm hoping we're ready to take both up and down risk at that point.
One of the things that we've been looking into at Accountable Care Law and Policy is the impact or the importance of post-acute care providers in the big picture. You know, you made an interesting point, and it's an accurate point, that we're trying to move away from hospital-centric care to patient-centered care, and basically trying to get to the lower cost points, which are outside the hospital typically. One of the things that we have found, particularly with the issue of readmissions to the hospital, is if you have some really good post-acute care providers, assisted living, SNF, therapy, and what have you, home care, you can do a great job of keeping people out of that readmission cycle. What are you guys doing to fill that gap in your organization?
Right, so we are working with nursing home providers. Our geriatrician staff are the medical directors of a number of nursing homes and post-acute care facilities. We've contracted with a home health care company through Johns Hopkins Health, which is a wonderful partner for GBMC Healthcare. And you're absolutely right. If it is your mom, you want your mom to be at home. If she can't be at home, you want her to be in the least intrusive place.
And you want her out of the hospital.
Right. You want her in the hospital if it's clear that she's going to get
Right,
benefit from being in the hospital and she's going to return to her previous state of well-being. But you don't want her in the hospital just because something is going on, and the country can't afford patients being in the hospital that are not deriving benefit from being in the hospital any longer. So as you point out, it's critical that the Accountable Care Organization integrate the patient-centered medical home with both hospitals and lower levels of care, post-acute care. I think it's been kind of I think the readmission movement has been kind of misguided because it's hospital-centric. I was driving into work today listening to this story of hospitals dealing with a pharmacy chain to help prevent readmissions. And we've put the locus of control in the wrong place. Hospitals have no hope of preventing readmissions. Physicians and patient-centered medical homes can do that. And I think that the conversation should not be around readmissions. The conversation should be about unnecessary admissions, period.
Good point.
And one of the reasons why there are so many unnecessary admissions is because the U.S. healthcare system is poorly designed and people use the emergency department as the pathway of least resistance. It really has very little, it has less to do with people going to the ED because they don't have health insurance. It has much more to do with people going to the ED because in the moment they have no other choice and they are not in an accountable system. Right. So many primary care offices act as if, well, we're busy, do whatever you need to do. By the way, why don't you go to the emergency department? Right. And we have emergency departments full of people with needs that don't have emergencies. Right. And those departments were built for emergencies. So we are working to keep those patients out of the hospital.
If you can just get the ones out who don't need to be there, it would be a tremendous improvement.
We would love to return the emergency department to an emergency department and have our loved ones getting care at a lower level. So we are delighted now that we serve patients on the weekends in our primary care offices who either would have gone to an urgent care center where it was somebody who didn't know them and didn't have their record, or they were going to the emergency department probably for a steep bill and a significant wait.
Now you just brought up the other point I wanted to delve into, and that is the application of your patient portal.
Yes.
I think that's a very fascinating concept, and I'd like to know, if my mom is in your system, how can she access, what can she get out of the portal, or me as her support person get out of the portal?
I would love Carson to present this as a brilliant idea, but sixth graders are not very impressed. So everything else in our life is done electronically. You know, I have my iPhone and you know, I'm getting directions, I'm making reservations, I'm checking my bank statement, and yet in healthcare, it looks like 1962. I'm calling on the phone, I'm on hold, I'm saying my child wants to play sports, I need a copy of his immunization records, could you mail it or fax it to me? And you know, the technology is so far beyond that. So we've embraced it and we've created a patient portal as part of our patient-centered medical home. So if you are at work and you say, uh-oh, Jimmy needs his immunization records for practice tonight, you can just go online and download Jimmy's immunization record yourself. If you're saying, you know, I need a primary care visit, but I don't have time to wait on the phone, you just go through the portal and say, I need a primary care visit, give me some options, and the office will give you some options. You choose them. You know, I have family members now that, you know, go for serious lab testing, and they're scared, and they're trying to get the result, and it takes them a week to get a result, and for a week they're scared, and I'm saying, why does it take a week for
Now,
them
if you
to
can
get
answer
the
that
result.
question, I'm really interested.
So the way we do it now is, you know, most laboratory results, even biopsy results, are resulted within 24 hours, and the physician gets the result. So now what happens is the result goes to the physician looks at it and sends it to the portal with a message. Here's what your result shows. You want to talk about this, call me. Here's my number. Or if you don't feel a need to call me, this is what you should do next. Then the patient goes on the portal, gets the message. If they want to have a conversation with the physician, they schedule it. If they don't, they've looked at the result and they're done. And you know, this is, I would love to take credit for this as some novel new thing, but the whole rest of the world already operates this way, so we're excited to do it for our patients.
Yeah, but doing it for your patients is rather unique.
It is unique, and it's an indictment on healthcare leaders that in the 21st century, it's still coming across as unique.
Yes.
But we won't lament the past. We're just trying to move forward and make it better for...
Well, there's certainly change on the horizon throughout the entire healthcare system, and I'm impressed at what you guys are doing here. And what I would like to do is ask you just sort of a general question to wrap up our session today.
Sure.
And that is, what topic have I not touched on that you find interesting or think our audience might be finding interesting and would like to know about?
Well, I think the whole conversation about reform of the healthcare system in the United States has been very sad because there really hasn't been any dialogue. It's just people yelling things at each other. And my plea...
And using buzzwords.
And using buzzwords. And my plea would be that the business community would step up and ask themselves, why are we paying 40% more than they are in Germany?
Yeah.
With no better outcomes, because the Germans are selling cars and we're selling cars, but the Germans have 40% lower health insurance costs for the people building those cars. And it's health care costs are strangling the rest of our economy. And my parting word would be to educated people to get in this redesigned boat with us. The American people need to say, what is it that they want? And then they need to hold accountable people like me to redesigning the system to get that.
Well, hopefully the new incentives will drive people in your direction, because I'm very impressed, as are my colleagues in my organization, about what you folks have accomplished here at Greater Baltimore. And I think you should be congratulated on being a pioneer and a leader in this space.
Well, thank you. We have a great team, and we're having a good time doing this, and we think we're
putting
doing
more
the right
joy
thing.
into healthcare.
Putting more joy into healthcare.
Thank you very much, Doctor, and thank you for hosting us today at your wonderful facility, and I appreciate the time.
Carson, thank you
Nice
very much
meeting
for
you.
taking the time to talk with us.
It was great. That's it from Greater Baltimore Medical Center today. Once again, we had what I consider to be a very insightful dialogue, and I hope those who watched will take to heart some of the suggestions that came out of that dialogue, because they're doing the right thing at the right time in this facility. Have a great day.